Program Director of the Division of Orthopedics Surgery in the University of Toronto. Thereafter, we shall swing into our discussion, the main thrust of this segment, which is the universal access to surgical services. Let us put our hands together as we invite Dr. Marcos to please come to the podium to do his lecture. It's already there.
Thank you for the kind introduction. It's an honor to be able to speak in front of this group. I'm a program director in orthopedic surgery from a long way to Dakar, to this wonderful city, and to meet hopefully people that may be interested in what we're doing in medical education in this part of the world. So as you may have heard, there's a change afoot in North America and other parts of the world, the UK, Australia, New Zealand, and Europe, about transitioning the way we train doctors into a competency-based lens. So in those parts of the world, when I give this talk, it's a common future. Jurisdictions in the world are become competency-based. But the question that I'd like to have at the end of this talk is, would this work for the training programs as part of the West African College of Surgeons? Because what may work in North America does not necessarily mean works in this part of the world, and there are a lot of reasons why. So let's start off with the understanding of what competency-based medical education is, and then at the end, hopefully, there'll be time for discussion, see if that may actually work for your countries. So the objectives of this talk are two-part. Project in the world to ever become competency-based completely in surgical training. So it's relevant to what you're doing. They sit down a model of training. And the question is, with develop the skills and knowledge. So that's led to a reduced time in the operating room learning skills and knowledge. There's another move around the world with regards to patient safety. In the old days, I could run an operating, my boss would be running one operating room, I'd run the other operating room, and at the end of the case, he'd look at the x-ray and said, good job or bad job. If it was a bad job, we have to take the patient back to the operating room. In the current system in North America, we can't do that because the surgeon and the hospital will get sued. So the time of independent training has been lost, okay? And the consequence of that, which is good for patients because mistakes aren't being made, is that there are decreased training opportunities for residents, okay? So this is the problem around North America, Europe, and Australia, and New Zealand. Our trainees aren't getting the time they need to practice to become competent. So what can we do about that? Well, one option is to lengthen training programs. Just say they need more time until we have that perfect cup of tea. The problem is, if medical students found that surgical training was instead of 5 years, maybe 7 years, they'd say, I don't want to be a surgeon. I'll do something else. I can graduate faster. I can live my life and make money sooner than I would if I wanted to be a surgeon. I go to family medicine or psychiatry. The other problem is an increased cost to the healthcare system. And I don't know about you, but I don't know any healthcare system has more money for medical education. So the governments are not willing to give more time to make sure we have that perfect cup of tea. So what can we do about that? Well, let's think about other ways of training our trainees. Alternate methods of curricular delivery. Time-based, get rid of the time-based model, or keep some of it, but focus more on competency-based training. Make sure the trainee is actually competent when they exit their training. So competency-based medical education, it's CBME. The definition is this: it's an outcomes-based approach to the design, implementation, assessment, and evaluation of medical education programs using an organized framework of competencies. So what we do in competency-based medical education is think, what do our trainees need to know when they exit the program to take care of patients? And we design a curriculum and assessment tools to make sure they get what they have to know when they graduate, okay? So it's outcomes-based approach. It's done to ensure that the physicians possess the knowledge and skills they need for every stage and role of their career. And you just don't have to think about what they need at the end of training. You can also develop a curriculum for every step of the training to make sure they know what they need before they move on to the next step. The rationale is as follows. It's a focus on curricular outcomes. We determine what trainees need to know, and we develop a curriculum to get there. We emphasize the trainees' abilities. So we teach and assess all the way through to make sure they get there. If they don't, then they need more time, they need more practice, we give them feedback. It de-emphasizes time-based training. So instead of saying you got 5 years, in some instances we may have a trainee needs a little extra, okay, maybe 6 years. But we may have trainees that are so exceptional they can get through faster, maybe 4 years. And the idea here is to promote greater learner-centeredness. We're focusing on the trainee, not necessarily the program. The program supports the trainee, not the other way around. That's difficult to do in our current culture. So the goal of competency-based medical education is to develop a competent doctor, okay? The trainee possesses the required abilities in all domains in a certain context at a defined stage of training. To become a competent doctor, they have to become competent in certain aspects of being a doctor, and these are known as competencies, okay? So these are observable abilities of health professionals which integrate multiple components such as knowledge, skills, values, and attitudes. And because they're observable, they can be measured and assessed. So we can determine the competency of a doctor or a surgeon training, for example, in how they communicate. Are they good at communicating with patients? Are they good at communicating with the healthcare team, the nurses, the anesthetists? We can determine their competencies. Are they good expert in medicine? Can they take care of surgical problems, post-operative complications? Are they competent in managing the affairs of their practice? Can they do things in a cost-effective manner, not wasting dollars or francs? In order to ensure our trainees are competent, we have to assess them at multiple time points. And with the tools that you would develop to determine competence, you determine where the trainee is in terms of their milestones of training. So one of the terms in competency-based medical education is a milestone. And that's an observable marker of an individual's ability along a developmental continuum, which is used for planning and teaching. So a trainee will have certain milestones to achieve until they're competent. The most important thing that we want to ensure our trainees are competent in is the skills relevant to our practice, okay? The entrustable professional acts. This is a big term in competency-based medical education as well. So an EPA is the current currency that we use to assess competence. It's a task in the clinical setting that may be delegated to a resident by their supervisor once sufficient competence has been demonstrated. And an EPA integrates multiple milestones, and it's used for overall assessment. So in our training program, a good example of an EPA is, can this trainee admit a patient with a hip fracture? Check. Can they fix that hip fracture? Check. Can they deal with the post-operative complications if somebody has a hip fracture? Check. They have the entrustable professional act signed off. They're assessed, they're given feedback, and once they have that checkbox for the EPA, then we know that they're competent in going forward and hopefully managing patients on their own independently. The important thing with the assessments is that we can develop as many assessments that we like, but they're no good unless we give feedback. So trainees need feedback on where they are. It just can't be summative, reviewing the percent score they may have on a multiple choice test or the assessment tools of their EPAs. It also has to be formative. We have to sit down with the trainee with protected time to discuss their strengths and weaknesses, not just at the end of a rotation, but perhaps a few time points during the rotation, at least halfway through, so the trainee knows where they are and we can modify the teaching plan for their needs. And again, that's how you identify an excellent trainee who may need less time, or a trainee that may need the average amount of time, or a trainee that may need more time. But feedback is very important for the process. So with this idea in mind, Canada has become a world leader in implementing competency-based medical education. Other countries in the world are doing it, but not every country has every specialty in medicine becoming competency-based like Canada. So the movement in Canada is known as competence by design. It's in the top right there, laser pointer there. I guess you can't even see it, but it's called competence by design. And really the whole idea is for the Royal College wants every resident in every specialty of medicine to become competent at every stage of their career. So this diagram here shows the different phases of training. We want trainees to become competent when they exit medical school, as a junior resident, as a senior resident, when they transition to practicing physicians, and then when they transition into retirement. It's a very ambitious project, and right now we're just focusing on the resident stage of competence, okay? So as I mentioned, every specialty in Canada will become competency-based by 2020. These are the rollout schedules for the different specialties, and these are just a few. There are over 80 specialties in medicine in Canada, but you can see it's a lot of work for the Royal College to implement this change, okay? Orthopedic surgery that I'm part of was supposed to start in 2018, but it's actually going to start in 2020. What the Royal College found with this big design, it actually took more years to plan and develop than they thought. So everything's actually been shifted by 2 years. It's a big undertaking. So despite what I've talked about competency-based education in the Royal College, and you may have heard it for the Royal College, is that The whole idea that the competency-based training program developed has actually been informed by a pilot project that we did in our surgical training program in Toronto. This is a picture of the Dean of Surgery 10, 15 years ago. His name is Richard Resnick, and it was his idea actually to do competency-based training in Toronto as a pilot study. And the Division of Orthopedic Surgery decided to do it as a pilot, and we started in 2009. So we would like to think that the work that we did was pioneering work to allow the Royal College to decide this was something that we should go ahead with for the whole country, okay? Other pilots have developed in other parts of the world. The Netherlands has done a bit, the UK, but we're the first to do it completely in orthopedic surgery. So now the phase of this talk is to talk about our experience in orthopedic surgery. And you can kind of think about, if you'd be interested in this in your jurisdictions, what steps you'd have to do in order to make it work. So our pilot in competency-based medical education has been there for 9.5 years. Again, we started in the summer of 2009, so it's almost a decade. So this is our experience. This is what we've been through. First off, as I mentioned again, we had to redesign the way our curriculum was developed. It was outcomes-based education. We wanted to think, what does an orthopedic surgery resident need to know when they graduate, when they go to take care of patients in their community? So we had to redesign the curriculum, the assessments, and the feedback, okay? With regards to that, we had 5 steps. So we sat down with our faculty, we sat down with our trainees, and we sat down with medical education experts in brainstorming sessions to think about what could we do to make sure that our curriculum was meeting the needs of our population going forward. Up until then, our curriculum document from our Royal College is over 10 or 15 years old. It didn't relate to what our trainees needed to know to service healthcare needs in Canada for orthopedic surgery at that time. So it was a chance to refresh our curriculum to think about, what do Canadian patients need from orthopedic surgeons at this time? So similar to Africa, the situation in Africa. What do patients in Africa need for their surgical specialties going forward? It's a chance to redevelop the curriculum. So out of that, we developed specific objectives. And with that, then we developed curriculum maps that the residents and the faculty could look at and say, okay, this is what the template is for training. Here are the forms that you need for teaching. Here are the forms for assessment. Okay, so we developed curriculum maps which outline the whole teaching plan. And out of that, we had to develop specific evaluation tools to determine competence. And then after that, we had to plan the implementation. The important thing to recognize is that our pilot project, at that time, we had 15 residents in each year of training. At that time, we took 3 residents in the pilot, and we have 12 residents in the regular stream, which is time-based. So it was actually challenging with administration to make our residents in the pilot stream go with the regular stream residents. But we made it work. Here's an example of the overall curriculum map, and this is something that you'd see in competency-based education. You don't have to read the fine details, but basically it breaks down the different phases of training of our residents. So phase 1 is a junior, phase 2 is an intermediate, phase 3 is a senior residents, and we outline all the different rotations they'd be on, and we teach and assess all the CAMEDS roles, or the core competencies of what it makes a complete doctor. And the different colors here: professionalism, collaborator, scholar, communicator, health expert, and or health advocate, and manager of the healthcare resources. The white represents the medical expert role, what they need to do to become a competent surgeon, but you can see we got an even distribution of teaching and assessment for all those core competencies or CAMEDS roles at every stage of training, across the phases and throughout all the 5 years of training. Out of the overall curriculum map, then each rotation or module would have its own curriculum map. And this outlines specifically what trainees would need to know. This is the example for the oncology module rotation. It has overall objectives, finer objectives. We have the source documents that the trainee would have to review. We have the specific competencies. We have the learning and teaching strategies. And then we have the evaluation method or tools that would be used to determine competence. These maps are multiple pages. I just have short pages here for brevity's sake. So with the curriculum then, with the teaching and assessment plan set in, then we come up with the evaluations. And the evaluation plan for our training program is expansive. We use oral and written exams. We assess how a trainee does a history and physical on a new patient in the clinic. We have those EPAs, those entrustable professional acts, particularly related to surgical procedures. And then we also do these intrinsic CAMEDS assessments, or the core competencies assessments, to make sure they're a well-rounded physician. Okay, here's an example of one of the forms we use for managing ankle fractures, EPA. It's multiple pages. I only have one slide here to be short. But essentially, for our assessors, we have a scoring rubric of the levels of competence. Okay, do they fail to meet, do they meet, or are they exceptional? For the most part, we want our trainees to become competent. They met the competencies of dealing with a patient with an ankle fracture. And there are different pages. The first one would be the pre-op care, the second page would be the intraoperative care, the third page, the post-operative care. So we break down the steps of care in managing patients with ankle fractures. And at the end of the rotation, then hopefully the resident will become competent and we can sign off on that EPA. We also use a lot of simulation in our environment, and this is a global rating scale that we use for the simulation lab. For our junior residents, we spend time in the simulation lab working on cadavers and artificial bone models before they actually work on patients, because it saves time in the operating room if the trainee can make a suture on a simulated model than compared to a patient, or do an osteotomy or fix a fracture on an artificial bone model before they go to the operating room. They have to become competent in this before they deal with patients in the operating room. And here's an example of those intrinsic chems roles or core competencies, collaborator and scholar. Okay, so we want our trainees to become competent in all those aspects of becoming a good surgeon. So the important thing, as I mentioned, is that you can develop the curriculum and the assessment tools, but if you don't tell the trainee how they're doing, it's not going to work. So our feedback is intensive, and really the idea here is to review performance in their assessments. It's done halfway through the rotation to make sure the trainee's on track, and at the end to finally sign things off. And it's summative and formative. Summative, we review the assessment scores, but then formative to give feedback on their strengths and weaknesses, help develop a learning plan for that trainee. It's different for everybody, so they exactly know where they're at and what they can do to get better. So despite that big change, it wasn't easy for us to have that on top of a regular stream training model, which was time-based. So we had to develop a specific infrastructure to make it work. At first, we started off with a paper format. Okay, we had a very old online resource server, but then we had to have paper form assessments, and that ended up failing because if you can think about your faculty, how many people would forget their assessment forms in their office on paper, not send it to the administrative office? It was a real nightmare. So as time went on, we developed a very good online server that had all the resources: the curriculum maps, the education tools, the assessment tools, and the case logs. And that's a server. So they have much more feedback, and we knew exactly where they were. This was a benefit for the training program because we could catch trainees in trouble early, and then we could help remediate them much sooner than we did in the old days. Okay? If you catch them early, you can sometimes turn people around and they can get there. The benefit for some trainees in our model was that if they were doing really well, they could graduate through the training program much sooner than 5 years. And some trainees actually got through in 4 years of training. Other trainees, for example,